Welcome everyone to another edition of UCSF Neurosurgery Community Grand Rounds. I'm Manish Aghi, and I'm really thrilled to be joined by my colleagues Sandeep Kunwar and Blevins from the California Center for Pituitary Disorders. And we're going to be talking today about the multidisciplinary care of pituitary tumor patients. Our panelists include neurosurgeons and neuroendocrinologists, but of course, when we speak to multidisciplinary care, it's really a comprehensive list of specialists, neuro-ophthalmology, otolaryngology, and radiation oncology, to just name a few. And we're going to present to you a few detailed case studies that illustrate the role that these team members play in getting patients through successful care at the CCPD at UCSF. So without further delay, I'll turn it over to Louis, who's going to get us started with our cases today.
All right, good morning, everyone. It's a pleasure to participate in this conference, and thanks for the introduction, Manish. The disclosures that I have relevant to this presentation are consultant for Corcept Therapeutics and Recordati. I believe that Manish and Sandeep had no other relevant disclosures to present today. So we'll start with this case of a patient who saw me several years ago. She was a 36-year-old woman who presented to her PCP with brain fog that she characterized as poor memory upon further elucidation of what she meant by brain fog. And she'd also had a weight gain of 40 pounds over the past year. Her PCP was very astute and recognized that she had hypertension, central weight redistribution, meaning that most of her excess weight was in the central portions of her body, and she had plethora of the face and proximal muscle weakness. And right away, the physician suspected that she might have hypercortisolism, so started an investigation. The 24-hour urine cortisol excretion rate was elevated at 174 micrograms, with normal being between 5 and 45. And she had a 1 milligram overnight dexamethasone suppression test of 14 micrograms per deciliter. This is where 1 milligram of dex is given at 11 p.m. and you check the cortisol at 8 a.m. In normal people, we expect dexamethasone to suppress the cortisol to less than 1.8 micrograms per deciliter. Her level did not suppress, as this indicated that she had pathologic cortisol secretion, and in conjunction with the elevated 24-hour urine cortisol, basically confirmed a diagnosis of hypercortisolism to match her physical features that were seen on examination. So this is our first polling question. What test or procedure would you order next? A 2-day dexamethasone suppression test, CT scan of the adrenal glands, a plasma ACTH level, an MRI of the pituitary gland, or would you simply proceed with pituitary surgery based on the findings presented so far? Can we see the results? So it looks like more than half the people chose MRI of the pituitary gland, another nearly half chose plasma ACTH, and then a few chose CT of the adrenal glands. So I would like to ask, this is not changing. Dr. Kunwar, could you please discuss how you would proceed next and maybe reflect on those answers presented as well?
Yeah, I mean, I think there's no, for the most part, wrong answer, perhaps, other than going straight to pituitary surgery. I think we know she's making excess cortisol, or she has hypercortisolism. And the fact that she did not suppress on low dose suggests it's not physiological hypercortisolemia from some sort of chronic stress state. So the key question now is, one, is does she have any exogenous sources? And that's just from looking at her medication list and making sure she's not taking any steroids of some sort. Second would be, is this Cushing's syndrome or Cushing's disease? Meaning, is it an ACTH-driven process or not? So really, is it coming from the adrenal glands or from an ACTH-producing tumor? ACTH would give us the key answer there. Is if the ACTH is elevated or normal, that really suggests an ACTH-driven process and therefore Cushing's disease. If it's really if the ACTH is very low, then that kind of would lead to a CT scan of the adrenal glands to look for adrenal mass.
Okay, so that's correct. So ACTH determination is the correct answer. Once you establish diagnosis of pathologic cortisol secretion, you have to determine if it's ACTH dependent or independent, as Dr. Kunwar alluded to. So let's move to the next slide. So this patient's ACTH level was 41. That's a normal result, normal between 10 and 65, but it's inappropriately normal because if cortisol levels are high, you're supposed to suppress ACTH unless ACTH is the driving process. So Dr. Aghi, what test would you order next?
Yeah, and before I get to that, just want to mention also that we want to make this as interactive as possible so the audience can feel free to post questions in the chat about anything about the case. But regarding the next step, as you mentioned, you've essentially confirmed a central source with this ACTH being inappropriately normal. And the next step would be to radiographically localize that source with a pituitary MRI.
Okay, so I wonder if you could read these films for us here.
Yeah, so these are coronal images of the pituitary gland, and the way the gadolinium gets taken up by the gland, we visualize relative hyper enhancement of the normal gland and stalk, but hypo enhancement would be consistent with an adenoma. In the inferior left abutting the cavernous sinus, we see hypo enhancement spanning from roughly the midline to the cavernous wall and along the inferior gland, as I mentioned, causing some slight rightward stalk deviation, which would also be consistent with it being an adenoma.
Okay, so polling question number 2. There is sufficient information to proceed with transfemoral surgery for presumed ACTH secreting pituitary adenoma, yes or no? And let's see the results. So 69% say yes, 31% no. So let's look at the next polling question. Polling question number 3, I would prefer IPSS prior to surgery in this situation, yes or no? IPSS is inferior petrosal sinus sampling, where we take blood from the petrosal sinuses and measure ACTH levels and compare that to blood in a peripheral vein and look at ratios before and after CRH or vasopressin administration to determine whether a patient has a central source, namely pituitary or paracellular tissues, versus an ectopic source. So would you do IPSS, yes or no? So let's look at the answer to that question. So 70% said no, 30% said yes. So, okay, very interesting. So Dr. Kunwar, how would you proceed? Please explain your rationale. And if you would, maybe both of you could comment on when you would use IPSS on a patient such as this one.
Yeah, so we know we've got ACH-dependent hypercortisolemia. We have a positive lesion on an MRI scan that shows a pituitary adenoma. There's no concerns about that. Typically in this situation, I would proceed with surgery. Doing IPSS is not unreasonable, although you always have to weigh the risk-benefit ratio. The purpose of doing the IPSS in this situation would be with the assumption that you have an ectopic ACTH source, which is very rare, in the setting of a non-functioning adenoma, which is not rare, but not common, but not rare either. So the likelihood of having 2 lesions, a very extremely rare ectopic source plus a non-functioning pituitary adenoma, would be so unlikely that does it really benefit you to accept the risks of an IPSS, which are overall very safe, but still has some associated problems that could develop. So in this situation where you have a documented MRI scan showing an adenoma that's fairly clear-cut, the fact that we know it's an ACTH-dependent process, I would proceed with surgery. I typically use IPSS nowadays only for if we have a good screening MRI scans. And one of the best MRI scans to look for small microadenomas is the use of dynamic imaging. And with dynamic imaging, if we still see no obvious tumor that's present or microadenoma that's present, and of course we can only detect lesions about 2 to 3 millimeters in size or larger, then I would proceed with IPSS to confirm not only a central source, meaning coming from the pituitary gland, but also sometimes occasionally can help us in lateralization to understand, is it on the left side or the right side of the gland based on the venous anatomy of the gland.
So the way I think about a patient like this is that if you have ACTH-dependent hypercortisolism, and a pituitary lesion, you can be probably 98% certain that this is the offending tumor and it needs to be removed. IPSS is only about 97% accurate. So you're already at that rate or that level of certainty that you would receive with IPSS. I think proceeding straight to surgery is fine. I don't see a problem with IPSS if you have uncertainty that's less than, say, 95% and want to have more certainty going to surgery. But in a patient like this, we tend to send straight to surgery rather than to the neuroradiologist for petrosal sinus sampling study. So this patient went to surgery. She had gross total resection of an ACTH immunopositive tumor. Her postoperative serum cortisol was excellent at 1 microgram per deciliter. When we take out a tumor that's producing ACTH that's driving the adrenals to function, the remaining normal pituitary cells that produce ACTH are suppressed. So when the tumor is removed, we expect the cortisol levels to fall and the ACTH levels to fall. So this was exactly as what we like to see happen in our patients. She required steroid supplementation for longer than usual. The average is about 10 to 12 months, but she took 2 years before she recovered HPA axis function. That was proved by low-dose ACTH stimulated cortisol. She lost 45 pounds in the first year after surgery, and her initial recovery, 24-hour urine cortisol, was 18 micrograms. And what I talk about a recovery is once her axis recovered, we give them a couple months. We check their urine cortisol to see where they are at their baseline, and then I check their cortisol levels every year, and I get a sense of where this patient is supposed to be when they're in remission or have been rendered disease-free from the surgery. So after a couple of years of follow-up, she was actually lost to follow-up for 2 or more years. And Dr. Aghi, so what are your thoughts? We'll do these questions one by one. First one, what are your thoughts on this data and the course presented when you see a patient who has these type of data after surgery? How do you feel as a surgeon when you see these data points?
Yeah, so postoperative hypocortisolemia, essentially undetectable cortisol, is really the gold standard for biochemical remission after transperinodal surgery for Cushing's disease. There is some variability in the time with which that's achieved, with some people arguing that immediate remission may be more durable than slightly delayed remission. But certainly based on the data that's presented here, this would be considered biochemical remission. So that would be my impression of the data in course. And I do think this patient, based on the postoperative data, was rendered disease-free. Recurrence is an interesting topic. There is fairly ample evidence in the literature to suggest that after biochemical remission, recurrence after Cushing's disease occurs in as many as 25 to 30% of patients. There is quite a wide range in the literature, with some series quoting even higher rates, but then some argue that some of those studies may have used insufficiently stringent criteria for remission to start with. And so perhaps some of those recurrences were never quite in remission. But there's also literature studies where very strict criteria for remission, such as what we saw here with a undetectable or virtually undetectable cortisol, and there's still an elevated amount of recurrence of about 15 to 20%. And so in some of these, although many of these recurrences are early in the first year or two after surgery, there's certainly cases and examples of patients who recur 10 to 20 years after initial remission. And so my sense, and some of this, is being done by the endocrinologist, but that these patients after remission end up having to be followed for life. But I would certainly defer to you on that, Louis.
Yeah, so the longest I've seen from initial surgery to recurrence is 28 years, and a couple of other people in the 20s. So I believe they should be followed for life. Many of these patients, however, are so happy to be free of this disease state, they recognize surgery worked. And after 3 to 5 years, they simply drop off our schedules and we never see them again, unless they do have a recurrence. So this patient came back 4 years or so after surgery, it's about 4.5 actually. And she presented for follow-up with complaints of insomnia and weight gain, and she felt like her Cushing's had recurred just because of these symptoms. And these are the two most common early symptoms of recurrence. She had no Cushing-like features on examination, whereas before she did. Her 24-hour urine cortisol was 41, so that's a normal result. Polling question number 4. What is the likelihood this patient has recurrent disease? Less than 5%? 25 to 50%, or 75 to 100%. And that's the likelihood based on the presentation. Okay, let's see our results. Okay, so 25 to 50%, a few on the wings of that as well. So Dr. Kunwar, what do you think? If this patient came to your clinic instead of mine, and you had actually operated on this patient, what would you tell her at the time?
Yeah, I mean, I think the fact that she took 2 years to have return of her CRH ACTH axis really suggests that she was cured. I mean, we know that if someone comes off their cortisol replacement therapy too soon, within 3 months or 6 months, oftentimes that means there's residual disease. The fact that she took so long really would suggest, and the fact that her biochemical profile early on was so good, really suggests that she should be, completely disease-free. But one of the things we've always learned about corticotrophic adenomas is that they're very aggressive tumors. Of all the pituitary adenomas, they're the most aggressive in the sense that even microscopic disease left behind will recur, whereas non-functioning other types of tumors, sometimes microscopic disease, even macroscopic disease, does not come back. Grow in the future. So you're always suspicious. With a normal 24-hour urine-free cortisol level, I'd want to do a dexamethasone suppression test perhaps. And of course, the last factor would be is to look at the salivary cortisol levels, midnight salivary cortisol levels, and if possible, look at the diurnal variations, either by cortisols or more easily salivary cortisol.
Okay. Very good. So the point is you don't stop at just a normal urine cortisol excretion rate. And we recognize that if the normal range is between 5 and 45, everybody has their own set point for cortisol secretion, and it's usually fairly tightly regulated. So someone might be normal at 20, but if they go to 40, they're going to have symptoms such as insomnia and weight gain. Whereas someone else may be normal at 40, but if they go to 20, they're going to have symptoms of adrenal insufficiency. So it's important to recognize that we do need additional information to further characterize the HPA axis function to determine if a patient has pathologic cortisol secretion. And the tests that we did were the dexamethasone suppression test. She failed that. Should have been less than 1.8, but her level was 14. Her late night salivary cortisol was 0.35 micrograms per deciliter. Normal is less than 0.1 at midnight. I also did a salivary cortisol profile on her. This is the profile in a normal person, where levels are highest in the morning, about half of that in the afternoon, and about 1/10 of that in the evening. And this was the profile in this patient. Now, we didn't need the profile. All we needed was this late night level, which is way up here at 0.35, relative to where it should have been under 0.1. But this shows that she has the loss of diurnal variation. So now we have symptoms and signs, an abnormal dex suppression test, an elevated late night salivary cortisol, and an abnormal salivary cortisol. So clearly this patient has biochemical evidence of recurrence. And this is what an early recurrence looks like: insomnia, weight gain, and abnormal physiology. So she had an MRI, and you can see here, this is the tumor bed with the postoperative atrophy of the tissues on this side of the intracellular contents. There was no surgically approachable lesion identified on this MRI. So what we would usually do in that situation is treat the patient medically. We treated her with ketoconazole to block steroid production by the adrenal glands. Her urine cortisol declined to 20 micrograms per 24 hours. And her clinical symptoms and signs improved, and then she was lost to follow-up again. And no idea where she is. Hopefully she's seeing a general endocrinologist and managing this condition. I'm sure she'll represent if a tumor ever rears its head in the future. So let's talk about some data that was alluded to earlier. This is a series from a paper that I published looking at the surgical results in Cushing's disease. And this was a focus on microadenomas And you can see here that the success rates are ranging between 92 to 69%. This paper by Gary Hammer and others, and I think Sandeep might have been part of that, I'm not sure, but this represented Charlie Wilson's experience at UCSF with a cure rate of 82% and a recurrence rate of 9%. But you can see they, as Manish said, recurrences go up to 20 to 30%. And then follow-up, of course, in these studies was of different duration. And once again, as was alluded to, the definition of cure and definition of recurrence has evolved over time and certainly has been secular throughout all of these particular studies. By the way, this is a paper that I published also at Emory University, reflecting George Tyndall's experience, 85% and 16% there for the microadenomas. For the macroadenomas, generally speaking, about 2/3 of patients are thought to be cured or rendered disease-free or in remission after initial surgery, again, depending on how you define that. And then anywhere between 12 and 36% of patients will have recurrent disease. So the macros, as we would expect, less initial successful surgical procedures with a higher rate of recurrent disease over time. There are a number of reasons you can have surgical failure. The first is the incorrect preoperative diagnosis. So maybe the patient really had ectopic ACTH hypersecretion and should have had IPSS. Sometimes you can go back and do that, even though venous blood flow dynamics may change, it can still be useful. Some patients who have ectopic pituitary adenomas located in the cavernous sinus, suprasellar region, or a stalk adenoma, if you're not expecting that or looking for that, when you find a negative pituitary exploration, you may have missed the tumor. A small proportion of people, and this might be overrated, have corticotroph hyperplasia. It's thought that this is 4% of patients with pituitary dependent Cushing's. I've only seen maybe one case in 30 plus years. A number of people do have pseudo Cushing's, and the biochemistry, if you're not savvy to interpreting test results, can look just like Cushing's, but this will be pseudo Cushing's due to depression, other psychiatric disorders, or alcoholism. And every once in a while, so we see factitious hypercortisolism. The key there is usually the ACTH is low because the patient is taking some exogenous steroid. If you look at patients who had incomplete or failed tumor resection, we know through some studies that Ed Laws has done that 8% of microadenomas are microinvasive. So when you take the tumor out, you biopsy the resection cavity, you'll see that 8% of patients still have residual pituitary tumor tissue present in that tumor bed. It's 62% of macroadenomas, so it's no surprise that a number of these people are going to recur. However, usually in our hands, recurrences aren't this high. That's probably because some of those cells are devascularized and ultimately become ischemic and die. If you look at the patients who go to surgery with a negative MRI and have an exploration, there's a 26% failure versus a 13% failure. And if you have negative histopathology, it's usually a 47% failure versus a 17% failure if there is histopathology. It's always important to ask the pathologist if they don't see a tumor, whether they see Crooks-Hyland change in the normal pituitary gland, because that is going to be present in most patients who have pathologic hypercortisolism. By the way, this is another patient of mine that had an invasive, as you can see here, tumor encircling the right carotid, or actually the patient's left carotid, and invading the cavernous sinus there. So she was not rendered disease-free from surgery, obviously. When it comes to identifying surgical failures or the postoperative evaluation, we've talked about the tests that we like to do. If you have elevated postoperative cortisol levels, and generally people like to use a cutoff of 2, we like to see them undetectable. But our own research at UCSF, looking at some of the patients early in the pituitary center and some of Charlie Wilson's patients, said that if you have an undetectable cortisol level, we were seeing recurrences in 4% of people. Interestingly, other studies have showed that if you have a normal cortisol level after surgery, you only get a relapse or recurrent hypercortisolism in 1/4 of people. We don't understand why that's the case. Many of these people may have smoldering hypercortisolism. Maybe some of the people that didn't have the relapses, their tumor is involuted or infarcted and they became in remission. There's been a lot of literature about checking the cortisol level 2 days after surgery. And if that's above a certain level, then you then go back to surgery immediately. However, studies, including this one over here on the right panel, have showed that cortisol levels 6 to 12 weeks after surgery are better predictors of remission than levels 2 days after. So we feel that it's reasonable to wait till 6 weeks. And then if we see residual or persistent hypercortisolism, then we can think about repeat surgery after we evaluate histopathology in the post-op MRI. Obviously, those patients who don't require glucocorticoids at all have failed surgery. And then there's some evidence that if you have a lack of diurnal variation in cortisol secretion, you have failed surgery, because if you've restored the patient to normal and the HP axis is recovered, if there's no diurnal variation, they may still have residual disease that will progress over time. And Estrada and others from Spain looked at this. And what they've shown here is, if you see the big black eye bars, this is the normal diurnal variation in cortisol levels, higher in the morning and lower at 11 p.m. The bolded dashed eye bars are showing patients who had a little bit of a fall in cortisol, but really didn't have the full normal diurnal variation. And then the less bolded eye bars show people who had no diurnal variation whatsoever. So they looked at these three different groups over time, and they saw that in group one, the patients that had the diurnal variation, the recurrence rate was only 3% over about a 10-year period of follow-up. And when they looked at the people who had maybe a little bit of fall in cortisol, but certainly weren't normal, the recurrence rate was 50%. And in the third group with absolutely no diurnal variation, 65% recurrence rate. So this assessment of the diurnal variation can be very useful in following patients long-term. This gives an example of one of our patients who was in remission. I think these data were obtained 5 years after original surgery, and the patient still was disease-free. And I decided to just check the cortisol levels as a proof of concept. And I did 3 salivary cortisol levels in the morning, 3 in the afternoon, about 30 minutes to an hour apart, and then 3 in the evening. And you can see here a nice preserved normal diurnal variation would indicate that this patient is not having a recurrence and is in a low likelihood of having a recurrence in the future. So the key messages so far, and I'm not finished yet, but the messages so far are that first you confirm hypercortisolism, then determine if it's ACTH dependent or not. IPSS is best used in patients with entirely negative MRI studies. Or if there's something going, maybe you expected a tumor, but you see something that looks like it might be a pars intermedia cyst, but could be a cystic tumor. That's a good reason to think about IPSS to determine whether or not there's a central source before you explore the cella. Patients with postoperative serum cortisol levels less than 2 microgram per deciliter probably are in remission, but still have an approximate 4% likelihood of recurrence. All these patients require long-term follow-up, especially because of the possibility that they can have a recurrence much later in life. The symptoms of early recurrence almost always include insomnia and an unexpected weight gain. And patients will come to the office to tell you, I think my Cushing's is back, because they lived with it before and they recognize when it's recurring, even when the 24-hour urine cortisol may be normal, but higher than their set point. So just keep in mind then that a normal, in quotes, urine-free cortisol excretion rate can be associated with symptoms. And loss of diurnal variation is the sine qua non of dysregulated cortisol secretion and can predict which patients will recur. Now, let's go back to Harvey Cushing and his report on Mini-G, published in 1912 and then again in 1914. This is the front page of the book that I have on my desk here in my home office that he published. And this is Mini-G, his patient, for whom he presented this patient. It's the first known presentation of a patient with this phenotype. And therefore the disease was named after him. This is what we used to teach, and we used to think about being hypercortisolism or Cushing's disease. And when you look at her symptoms and signs, she had amenorrhea, headaches, weight gain, insomnia, easy bruising, excess facial hair, stomach and back pain, plethora, hirsutism, easy bruising, hyperpigmentation, central obesity, abdominal stria, muscle wasting, all of the classic things that we think of as hypercortisolism today. Interestingly, he did not find a pituitary tumor in this patient. He did not operate on her pituitary gland whatsoever. he operated on her for a potential diagnosis of hydrocephalus, and he describes in his report that he incised the arachnoid and CSF spurted out. So he was certain this patient had hydrocephalus, and that was the operation that she needed. He had her in the hospital for about 110 days. Can you imagine that? If the neurosurgery service was full of patients now, he had a craniotomy and we're in the hospital for 110 days or so. It was just shy of 110 days, but that's sort of the rough guesstimate there. He saw her multiple times throughout his career. Once he left Hopkins and went to Boston, I believe she traveled to Boston to see him. He never diagnosed a pituitary adenoma. At one point, he suspected that she may have some form of an adrenal problem, because at the time, there were a number of patients who were thought to have adrenal disease and a similar appearance. And again, this was before we could measure any urinary steroids or plasma steroids. That didn't happen until the 1940s. This was 1912 when he first presented this case. Interestingly, one of the other first associations ever reported with a patient who had a pituitary lesion and symptoms like this happened at UCSF in the 1930s. I don't remember the name of the surgeon who presented that, but our institution has a bit of a history in this field as well. I've told you these things. Oh, the other thing is she lived 50 years or so after craniotomy, which would have been unusual for a patient with true Cushing's, even though she looked Cushingoid. In that era, there were no anti-infectives. People died of infections, hypertension, diabetes complications, et cetera. There were no treatments for that. So the fact that she lived 50 years was a little bit unusual for a Cushing's patient, because studies in the 1950s showed that the 5-year mortality of untreated hypercortisolism was 50%. So that was an unusual feature of her clinical presentation as well. So the important thing to keep in mind in this era is that not all patients with hypercortisolism look Cushingoid, even though we've named this syndrome after Harvey Cushing, and we think about this Cushingoid appearance. I would have to say that in my practice, in the 35 years that I've been a physician, 36 years, the Cushingoid appearance in patients with pituitary adenomas or adrenal tumors is less common than it used to be. And I think this is because we're diagnosing patients sooner rather than later. And instead, most patients have one or more subtle to moderate symptoms and signs of hypercortisolism. Many present with just a gateway diagnosis, such as diabetes, hypertension, osteoporosis, an unusual infection, or a deep vein thrombosis. And it's the astute clinician who will recognize that there are 2 or 3 things here that might be part of Cushing's rather than the entire full-blown syndrome. And I think this, based on my experience, the clinical presentation depends on the underlying cause. Those with ectopic ACTH have a more florid, rapid presentation than those with adrenal disease or those with pituitary disease. The duration of hypercortisolism and the severity of such also play a role in the clinical presentation. But I think that also it's tissue sensitivity to steroids. Some people get diabetes, about 35%, the rest don't. Some people have weight gain. They probably have underlying metabolic syndrome with hypercortisolism on top of that. So there are these genetic predispositions and other risk factors. Maybe some start with a low bone density, present with osteoporosis. Lots of different things play a role. And as a result, you get a heterogeneous disorder where Manish-Aghi and the Cushingoid appearance really is at the tail end of the bell-shaped curve of the clinical presentation of Cushing's. And I've seen people who had no weight gain whatsoever, just had myopathy and hypercholesterolemia as their presentation. And I've seen people that look just like Manish-Aghi. The point I wanted to leave you with is the fact that not all patients look Cushingoid, and you need to be aware that just because a patient comes in and doesn't really look like they have Cushing's doesn't mean they don't have it. And we see that in our practice nearly every single day.
There's one question from the audience. So question is, since diurnal variation seems so predictive for recurrence, what are your thoughts about the value of routinely getting a salivary cortisol on all post-ops?
I'm inclined to do that in patients who have returned their HPA axis to normal. If they still have low cortisol levels and require steroid supplementation, I tend not to be interested in the salivary cortisol. But once they come off steroids and are now free and thought to be in remission, I think that's the best time to check it.
Great. All right, well, I'm going to go ahead and share screen. Hopefully everyone can see that. So this is a 62-year-old male who presented to his PCP with dizziness, blurry vision, and emesis. He was a little hypertensive and obese, but otherwise he had no deficits on exam, and his appearance was just that of a typical obese male in his early 60s, but nothing particularly striking. I've put up on the screen some laboratory tests, and Lewis, I'd be curious as to your interpretation of these.
So it appears that most tests are normal. A few things are low normal. The IGF binding protein, IGF-1 binding protein is not the test that we usually like to see, but sometimes labs make the error and check that instead of an IGF-1. There is a correlation between that and IGF-1, but this low suggesting to me possible growth hormone deficiency. The ACTH and the cortisol are sufficient. The total testosterone, free testosterone, LH make me wonder whether this patient might have mild hypogonadism. Certainly there's no hyperprolactinemia. And then the T4 level being at the low part of the normal range always makes me wonder whether there's been some compromise of pituitary thyroid function in this patient. So I would say that there's a possibility here of mild hypopituitarism with definite growth hormone deficiency, possible hypogonadism, maybe mild hypothyroidism.
Great. And then this is the imaging. Sandeep, I don't know if you have any thoughts.
Yeah, it looks like he has a cystic pituitary lesion. You can see marked atrophy of the pituitary gland itself, and two things can live in the same space. So you can see on the coronal right image, that's post-contrast. Stalk is slightly deviated towards the left-hand side. Large right-sided cystic lesion. You can see a solid portion, a large liquid portion, fluid-filled portion to it. There's no supracellular extension. The optic nerves are not affected. But I think the fact that he's got, if you think about the normal pituitary gland being 12 millimeters and his being about 2 millimeters, you can see why he may have some mild essential hypogonadism as well as hypothyroidism. There is a small solid lesion on the side. And so this is more consistent with a cystic adenoma rather than a Rathke's cleft cyst, for example, where the stalk would be deviated forward and would still remain midline.
Great. Yeah, so based on that, I have another poll if we could, and the question is just what you would recommend observing. I mean, obviously, patient has good vision and, is doing reasonably well versus transsphenoidal surgery in light of some of the imaging findings and labs. All right, maybe we can check the results. So pretty good split. And I guess in terms of our panelists, Sandeep, would you consider this based on laboratory values to be a symptomatic lesion and not an incidentaloma?
Yeah, I think, we think of signs and symptoms, and one of the key elements here is that, we always think about vision loss as being the key driver to treating these lesions, and there's no question that's true. We also know any hypersecretion drives a small or larger lesion, but this is not really a small lesion in the sense that he has probably lost of about 85% of his glandular tissue. And as this lesion grows, he will lose more gland tissue and eventually become hypopit. Of course, yes, we can replace every hormone that exists, but as you know, based on the Lancet study, that we do not do as good of a job replacing it versus the patient having its own production. The odds ratio for mortality was 1.9 times higher in patients with panhypopituitarism despite replacement therapy. So in this situation, in order to preserve what remains, and again, this is related to the surgical risks potentially, is if you can remove this without causing further damage, then there would be some strong indication to do transsphenoidal surgery in order to preserve what remains of his gland, prevent future growth of this lesion. And oftentimes cystic lesions will grow faster than solid lesions. And that's just a fact of physics in the sense that fluid, like a blister, can develop within a short period of time, versus solid tumor growing has to require cellular division, and the labeling index of most of these tumors are quite low. So although the solid portion may grow slower, the cystic portion can potentially grow faster. And oftentimes, cystic lesions will cause more damage to the gland. And this may be an exact example of that, is that a lesion this small, if it was solid, I would not expect to have hypothyroidism, maybe hypogonadism and growth hormone deficiency. But a fluid-filled lesion may not have grown over 5 or 8 years, may have grown over 1 or 2 years, in which case a faster growing lesion will cause more damage to the normal gland. So I think for those reasons, I would recommend transnodal surgeries based on this situation.
Great. So that is what was done. At surgery, cyst and solid tumor were both removed. Postoperatively, as you alluded to, there's not a lot of gland left, but there is some visible gland and no residual lesion. So this is the pathology report that came back. You mentioned labeling index, that was around 2%. So generally anything below 3% is at least reassuring that it's not unusually proliferative. But the overall pattern of staining here revealed some ACTH staining, as well as some staining for the TPIT transcription factor, which goes with a diagnosis of a corticotroph adenoma. But because the staining was patchy, it was considered the sparsely granulated subtype, which I'll get to in a moment. But when we get these reports, the pathologist will always say correlate with symptoms, because now you've got essentially what on paper, this patient is getting back the same pathology report as the previous patient. And, they're going to come to you and say, I have corticotroph adenoma. And so the question is, as we correlate that with symptoms, what would we consider the diagnosis here? Lewis, I guess I can ask.
Yeah, so it's always interesting to see these patients who have corticotroph adenomas. We have a lot of experience with them at our institution. And these adenomas can be either functional or non-functional or weakly functional. In general, if you look at data from Sylvia Asa and others, it's said that of all tumors that come to the pathology laboratory that's immunostained for ACTH and TPIT, 45% of them were not associated with hormone hypersecretion, whereas 55% were. So this is sort of a big or a strong component of those patients that are thought to have non-functioning tumors. And I always like to look at their symptoms and signs. When I see this in the postoperative setting, and a patient thought to have a non-functioning tumor, I always like to look at their symptoms and signs and pay careful attention to what their ACTH and their cortisol levels were before surgery, and also to assess what they are after surgery. Because if they're not disease-free and they have evidence of autonomous cortisol secretion, they may need some additional treatment.
Great. So that's what was done here. So we didn't get an immediate, post-op lab. We weren't presuming a diagnosis of Cushing's disease, but this is what we saw at 6 weeks. And Lewis, if you want to comment on this.
So this profile shows to me some improvement in pituitary function. The IGF-1 is normal. The T4 and T3 levels are normal. The testosterone levels are normal. The free testosterone is increased from 50 to 73. So this is exactly why we operate on patients with the characteristics of your patient. We want to improve pituitary function. But curiously, what we see here is the cortisol level is less than 2 and the ACTH is 8. And to me, this profile suggests that tumor was producing ACTH. And even when the ACTH and cortisol were not elevated, it was probably maintaining normal adrenal function, if you will, and looking like the patient had reasonably preserved adrenal function, whereas everything else was slightly out. Now, after surgery, everything else is better, but this is low, suggesting to me that tumor was producing ACTH. The adrenal glands were responding, the cortisol levels were normal. You take the tumor out, you've taken out the drive for adrenal production, and now the rest of the corticotrophs, if there's sufficient amount, and there probably is given the pituitary function's normal, we're just going to have to recover from the suppression from the autonomous production of ACTH by the tumor.
Yeah, exactly. And, I think new pituitary deficits after surgery are thankfully quite rare. And certainly a scenario where one axis, such as cortisol, is just completely knocked out and every other axis is either, as you point out, is better, would be highly unusual as an iatrogenic effect from surgery. So this suggests that the biology of the tumor is essentially a Cushing's picture where it was suppressing the normal gland. And now that the tumor is out, we're seeing hypocortisolemia. And so we, at that point moving forward, managed the patient similar to the previous patient where we kept them on dexamethasone for an extended duration. And then at 1 year, we were able to get recovery of function. I think at this level, Lewis, I'm curious if you would still get an ACTH stimulation test to prove that they can come off dexamethasone replacement. What's your decision-making in terms of just seeing a random cortisol in a post-op patient, and when would you get an ACTH stim test to reassure yourself?
So if I saw, excuse me, if I saw these levels in a person that didn't have a corticotrophic adenoma, I wouldn't do further testing, just because the IGF-1 is normal, the thyroid function is normal, testosterone is normal. But in a patient who we knew had Cushing's, I would think they're almost recovered, maybe not entirely. When you have a cortisol over 12, you can just assume that the patient doesn't require steroids. Anything less than 12 probably would do a stim test or might do a stim test. It just depends on how the patient's doing to see whether they could come off the dexamethasone or whatever other steroid they were taking. Generally, if it's under 5, cortisol is under 5 at 8 o'clock in the morning, they're going to require steroids. I start doing stimulation tests when they're around 7 to 8. If they're 12, I come off it altogether. In a patient like this, I would probably do a stimulation test 60% of the time, 40% of the time. I might say, stop your steroid and see what happens. Or may say, let's check another cortisol in a couple of months. And then if it's over 12, stop it.
Great. So a polling question that we've sort of alluded to the answers, but what is the diagnosis, silent corticotrophic versus Cushing's disease for this patient? And we can get the results. Oh, interesting. So yeah, no, I mean, I think obviously we don't have definitive proof. We don't have a preoperative salivary cortisol. And so in this one, people were favoring a silent. So that does bring me to just one slide I wanted to present on silent corticotrophic adenomas. This is our series that is now 10 years old, but it's been fairly durable in its result, which is this idea that much like Cushing's disease, as Lewis presented, has an elevated risk of recurrence. Silent corticotrophic adenomas do have an elevated risk of recurrence. And this is that distinction between the type 1s where the ACTH staining is uniform versus the sparse staining that is just considered a type 2. And that gets at the pathology report that mentioned the sparsely granulated subtype. And the dense staining type 1s have a long-term recurrence rate of about 40%. The type 2s have a recurrence that in the long run is comparable to hormone negative or non-functioning tumors that I call it hormone negative because meaning that don't stain for ACTH. But they do even the type 2s, which like our patient had, do recur earlier than hormone negative tumors. So by Kaplan-Meier analysis, both types of silent corticotrophic adenomas recur more frequently than tumors that don't stain for ACTH. But again, with our patient, we were more convinced that this was a sort of a Cushing's disease case that just didn't get identified preoperatively. But so that's our last slide. We do have I'm going to stop screen sharing, and we have a question in the chat for the group. What are some preoperative predictors of how long patients would need postoperative steroid supplementation? I think it's a good question, and I'll give that to you, Lewis.
So I am not aware of any. I have seen patients who had florid hypercortisolism with very profoundly elevated cortisol levels. And I think they're more likely to have steroid withdrawal symptoms after surgery on steroid replacement therapy. And they tend to recover sometimes sooner than those who have had lesser severe elevations in cortisol secretion. I've looked for it. I haven't seen any preoperative predictors as to how long patients are going to require steroids. It may have something to do with, again, duration of disease, tissue effect, magnitude of elevation. So I really couldn't answer that question with any certainty.
All right. Another question is that when you get someone assessed, they obviously have to hold steroid supplementation. What are some precautions you tell patients during that period of time when they're off steroids just to get assessed?
So our goal is to hold steroids for about 48 hours before we do testing. And when you give a replacement dose of dexamethasone, if the patient is able to make their own ACTH and cortisol, their levels will usually be normal. If they have either adrenal insufficiency or continued suppression, they're not going to make normal cortisol. So 48 hours seems to be a reasonable amount of time. Because of the half-life of dexamethasone being about 18 to 30 hours, usually about 18 hours, most patients aren't going to have any symptoms and signs of adrenal insufficiency. However, we have seen those on occasion where patients will talk about nausea, vomiting, or profound weakness, beginning oftentimes about 12 hours after their last dose of medication. In those patients, we have them go ahead and go back on the steroids because they've declared themselves as probably still adrenally insufficient. And then we'll just try again a month or two later to get that level. But generally speaking, and you see this often in pediatrics, kids with adrenal insufficiency, they don't take their medications. Their parents are hounding them to take their medicine all the time. They'll be without steroids for weeks on end and have no real symptoms and signs of adrenal insufficiency. But it's only when they have a crisis such as the flu or COVID or an accident or an injury that their body is challenged and the steroid deficiency manifests itself. Plenty of patients out there in the world don't take their steroids. We have patients that are late getting their refills. They usually do fine. So there aren't any real precautions to tell people, but usually those who have had a history of Cushing's and are recovering, they may have a little bit more symptomatology associated with missing their dose for a few days.
Great. Well, this has been a great discussion. Sandeep, any final thoughts on Cushing's disease from a surgeon's perspective?
Yeah, and I mean, of all probably tumors that we treat, the Cushing's patients are probably the most critical in regards to the surgical aspects of tumor resection, just because of how aggressive these tumors can be, the microscopic disease that could be left behind or recurring in the future. And so of all the tumors, we talk about a pseudocapsular resection, and very critical to do that for these Cushing's tumors is to remove that pseudocapsule with the tumor that kind of is a netting around the tumor. And we can do that without causing significant damage to the gland and have a higher likelihood of removing all the tumor, including the microscopic disease. The other advantage of the pseudocapsular dissection along the gland side, there's, between the tumor and the gland, there'll always be a pseudocapsule, is that can make sure that there's no residual disease along the gland. And for example, that first case, most likely the recurrence was from the cavernous sinus wall. That's either the bone or the cavernous sinus are the two areas of highest likelihood of recurrence. If we ever see a cavernous wall that doesn't have the typical violet purple color, it's not unreasonable to open up the cavernous sinus, especially inferiorly where it can be done safely, to explore if there's any gross disease that can be removed. And then the other issue is going to be in those situations, if the patient does have recurrence, and although medical therapy is an option, the other option would also be using, getting our radiation oncologist colleagues involved and doing gamma knife radiosurgery. With gamma knife, we can target the clival floor, we can target the cavernous wall, and the main risk of radiation therapy is damage to the gland, in this situation. But really, that's dependent on the distance between where we're targeting versus where the pituitary stalk is. So again, if you're targeting the cavernous wall, in her case, the pituitary stalk is 4 or 5 millimeters away. With sub-millimeter accuracy that we have with gamma knife, if we can, if the stalk is more than 2 to 3 millimeters away, we can do so with minimal risk to the pituitary function as well. And that may provide long-term control, although the ketoconazole definitely will provide short-term control. It's long-term control that may be benefited.
Great. Thank you, everyone, for joining. And thanks to our panelists, Louis and Sandeep, for doing this. So this series is our community grand rounds where we, embedded in neurosurgery grand rounds where we interact with neurosurgeons and specialists in the community in a case-based fashion. We hope you've enjoyed this. The series will be on pause for the summer or the rest of the summer, but we'll resume in October and November with panelists discussing functional neurosurgery, skull-base surgery, and neuro-oncology. So we hope you can all join for those sessions, which will be announced on social media and various listservs. Thank you again.